Welcome to today's webinar, Improving Care for Dual Eligibles, How States Are Innovating Through Medicare Advantage D-SNP Plans. I'm Trish Riley with the National Academy for State Health Policy, and I'm very pleased to be your webinar moderator. This webinar is supported by the Commonwealth Fund, and we're deeply appreciative for their support. I want to thank Jen Jensen and Olivia Bacon from our staff for help to get us here today, and thank all of you for joining us. This webinar will explore how states can use contracts with Medicare Advantage D-SNP plans to improve care for dual eligibles, advance Medicare and Medicaid alignment, and support broader payment and delivery system reform. Dual eligible special needs plans, D-SNPs, are Medicare Advantage plans that serve individuals who are eligible for both Medicare and Medicaid. To operate in a state, D-SNP plans must have a contract with the state that describes the plan's responsibility to coordinate Medicare and Medicaid benefits. We have a great panel today and plenty of time for your questions and answers. We will begin with a brief overview of D-SNP policies by CMS and then hear from speakers from Arizona, Minnesota, and Tennessee. Before we get started and before I introduce the panel, I want to focus on just a couple housekeeping items. First, the web-based interaction and phone lines that are supporting this webinar. Many of you should be able to listen to the webinar through your computers, but if not, phone lines are also available, and the 877 number was listed on your slide, 877-870-4401. At any point you can ask a question by typing it into the chat box located at the bottom left of your screen. We will be responding to these questions during the Q&A portions of the webinar. So chat away, please be sure to add them. The slides and the recording of this webinar will be posted on NASHB's website in the next few days. So you will have the access to the available material today. So let me then introduce our great speakers, again, in the order in which they'll make presentations. To kick us off from CMS and give the overview, Nisha Marie Sherry Romanek. She's the Director of the Division of Policy Analysis and Planning, Medicare Drug and Health Plan Contract Administration Group, CMCS. Tom Betlach joins us next as the Director of the Arizona Healthcare Cost Containment System. He'll be followed by Gretchen Olby, Manager of Special Needs Purchasing for the Minnesota Department of Human Services. And finally, Patty Killingsworth, Assistant Commissioner and Long-Term Care Chief of TennCare, Department of Finance and Administration, State of Tennessee, will wrap up before we move to your questions. So with that, let me turn and kick us off and ask Nisha to begin.
Thank you so much, Trish. Good afternoon. My name is Nisha Sherry, as Trish mentioned, and I'm going to give an overview about D-SNPs and also contracting with states. Let's go to the next slide. So over the next couple of minutes, I'm going to be talking a little bit of background on D-SNPs, the state Medicaid agency contract requirements required by CMS, the MIPPA elements that are part of those requirements, our fully integrated dual eligible SNPs, which are the most integrated of the dual SNPs, and some points of consideration for contracting. Next, please. So D-SNPs, under CMS, our Medicare Advantage plans, there's 3 types of special needs plans, and D-SNPs are one of them. The D-SNPs, so the SNPs were authorized in the Medicare Modernization Act of 2003 and began operating in January 2006. D-SNPs are intended to allow Medicare Advantage plans to specialize in serving beneficiaries who are both eligible for Medicare and Medicaid. Initially, there was no requirement that D-SNPs have a formal relationship with state Medicaid agencies. However, that changed under MIPPA, and now all states that wish to operate D-SNPs, or all rather Medicare Advantage organizations that wish to operate D-SNPs, must have an approved state Medicaid agency contract in order to operate them in the state. States vary in determining the eligibility categories covered under Medicaid, so they can vary by QIMBY, SLIMBY, on who they will permit to enroll in the D-SNPs. But the D-SNPs must limit enrollment to the dual eligible categories under the state contract. those categories are based on the percentage of federal poverty level and can be found at the link listed in the slide. Next. So as I mentioned initially, there was no requirement for D-SNPs to have a contract with the state, but as of January 2013, with the Medicare Improvements for Patients and Providers Act of 2008, which was amended by the Affordable Care Act of 2010, that required all D-SNPs to have a contract with the state Medicaid agency in each state in which they operate to provide Medicaid benefits or arrange for benefits to be provided by calendar year 2013. So what we require of the state Medicaid agency contracts, they must at a minimum include all of the 8 what we call MIPPA elements, which I'll go into in the next couple slides. They must show that the D-SNPs agrees to provide Medicaid benefits or arrange for benefits to be provided, and they must show that the state Medicaid agency agrees to allow the D-SNP to serve and coordinate care for Medicare and Medicaid enrollees. As a note, and I think this is going to be a theme throughout the presentation, it's really the state's discretion as to what they want to require in addition to those MIPPA elements. And for the purposes of CMS approval, all the contracts must have all of the 8 MIPPA elements, but it's the state's prerogative whether they want to go above and beyond those elements in requirements for the D-SNPs in their states. Next slide, please. So as I mentioned, there's 8 MIPPA elements that must be included in the contracts. The first of that is that the MA organization's responsibility, including financial obligations to provide or arrange for Medicaid benefits, must be specified in the contract. The contracts must clearly outline the process by which the D-SNP agency provides for and arranges for Medicaid benefits, and all contracts must specify how the Medicare and Medicaid benefits are integrated and or coordinated. The second MIPPA element is that the contract must specify the categories of eligibility for dually eligible beneficiaries to be enrolled. As I mentioned before, that's up to the discretion of the state in terms of what categories of duals they want to permit to enroll in their D-SNPs. The third is Medicaid benefits covered under the SNP. So the contracts must include information on benefit design and administration and the assignment of responsibility for providing or arranging for the covered benefits. That includes, there's a wide range of what we consider to be arranged for benefits, and that includes everything from Medicaid fee-for-service to the more integrated D-SNPs that we have where it's under a single managed care organization. The fourth element is cost-sharing protections covered under the D-SNP, and the contracts must affirm that the D-SNP will not impose cost-sharing on specified dually eligible beneficiaries that exceeds the amount permitted under the state Medicaid plan if the individual were not enrolled in the D-SNP. Next slide, please. So element 5 is the identification and sharing information on Medicaid provider participation. So the contracts must describe the process by which the state will identify and share information on providers contracted with the state Medicaid agency for inclusion in the SNP provider directory. The sixth element is verification of the enrollee's eligibility for those to be in the D-SNP, and that contracts must ensure that the D-SNP will receive real-time access to information from the state to verify the eligibility of dual eligible enrollees. Element 7, the service area covered by the SNP. So this is in Medicare Advantage, we require that all Medicare Advantage plans specify the service area in which they operate, and that's part of what we require for SNPs as well. The SNP must clearly identify, the contract must clearly identify the covered service areas in which the state has agreed that the Medicare Advantage organization may market and enroll. And last but not least, the contract period for the SNP. So we require that the contracts that are submitted to CMS by July 1st of the year preceding the contract year in which the SNP wants to operate, that the contract cover the entire calendar year from January 1st through December 31st. So that we will touch on later as points of consideration, as CMS is aware that the contracting cycle for states does not always strictly follow that calendar year from January 1 to December 31st. Next slide, please. So as I mentioned earlier, we have what are called fully integrated dual eligible SNPs, and those are our the most highly integrated SNPs, and they align with Medicare and Medicaid care management and provide access under a single managed care organization. They offer a capitated benefit package that includes LTSS benefits, and they employ CMS and state-approved policies and procedures to coordinate or integrate enrollment, member materials, communications, grievance and appeals, and quality improvement. In order to qualify as a fully integrated dual eligible SNP, a organization, when they submit their state Medicaid agency contract in July 1st of the year preceding the year in which they wish to operate, that contract is also reviewed for what we call fully integrated dual eligible status. If it meets the requirements, then CMS grants that D-SNP as a FIDE for that contract year, in which case they become eligible for a frailty adjustment payment if they meet the frailty level of individuals enrolled in PACE. As I mentioned, the FIDE SNP eligibility has to be reassessed every year, and that occurs when the organization submits their contract in July. Next slide, please. So here are some points of consideration when thinking about D-SNPs and state contracts. So all D-SNPs, as they are Medicare Advantage plans, must meet all CMS Medicare Advantage contracting requirements, including all SNP requirements, and those are model of care, and as well as the D-SNP requirements, which include the contracting with the state. So D-SNPs must provide CMS with a state Medicaid agency contract by July 1st of the year prior to which they plan to operate. That contract that they submit must meet all of the MIPPA requirements in order for the D-SNP to be approved for the following contract year. States are not required to contract with D-SNPs. It's their prerogative, and CMS defers to states if they decide there are certain organizations they do not wish to contract with. That's not something that CMS would get involved with. States also have broad discretion in contracting with D-SNPs as long as their state Medicaid agency contract is compliant with the MIPPA requirements. The state can go above and beyond in terms of requirements for further integration of their D-SNPs. States can offer MIPPA contracts to all D-SNPs or require Medicaid health plan contractors to be approved D-SNPs to create opportunities for aligned enrollment and benefit integration. On this slide, I've listed some examples of how certain states are going beyond just the basic MIPPA requirements. For example, some states require that some or all MLTSS contractors to be D-SNPs. States can also contract with only D-SNPs that have state MLTSS contracts, and states can limit D-SNPs they contract with to those that meet the requirements under both voluntary and mandatory Medicaid managed care enrollment design. Next slide. So as I mentioned, this was just an overview of our federal requirements for D-SNPs, but we are happy to be a resource, and if there's any questions, I've provided some resources for you as well as mailboxes to which you guys can ask questions as well.
Great, Nisha, thank you so much. Good thing there's no acronyms in this field. That's what I say.
Exactly. As soon as you think you know them, there's like 10 more.
Exactly. There's a quiz at the end, everybody, just on acronyms. But let's move on and remind everyone that there is a chat box. So as you have questions, please add them, and we will get them answered as we go. So add your questions as you think of them. Let's move on now to Tom Betlach. You probably noted that Arizona was in all three of Nisha's examples, so what better place to start than with Tom Betlach?
Thanks, Trish. Good morning. Good afternoon, everybody from Arizona. This first slide is brought to you not only by the Medicaid agency, but by the State Tourism Board for those of you doing your spring planning, spring break planning, where it's 70 degrees right now. But really, I put this up here really when you look at our strategic plan, the D-SNP strategy is involved in all four components. So it's part of our strategy to bend the cost curve and improve outcomes, pursue continuous quality improvement, reducing fragmentation, and really in order for us to be able to achieve all these things, we need the core capacity to manage all of that and the complexity and the acronyms that were mentioned earlier. Next slide, please. So just to capture what's happened in Arizona over the last many years in the course of the next 4 minutes, we started back with the passage of the Medicare Modernization Act in Part D by having our plans get engaged in terms of what it would take to become a D-SNP and leverage that for part of the transition for the Part D drug. And we were successful in doing that. Many plans stepped forward, not all plans. And we were able to get some limited passive enrollment to get some membership enrollment for our plans as part of that. So we have a long history in terms of partnering with our managed care organizations around the D-SNP product. We established a statute as part of that process. So in Arizona, the Medicaid agency is able to regulate the managed care organizations without them having to go through the Department of Insurance, and we extended that to the D-SNP product. So they still have to go through CMS and Medicare and all that fun stuff, but we can serve as the regulatory oversight organization locally as it relates to the D-SNP products for our managed care organizations. One of the important things that I would encourage any state to look at is as you're creating your strategies around the dual eligibles to have dedicated staff associated with those strategies. And so it's complex. There's a lot of moving pieces. The plans require somebody that they can interface with that understands the complexities of the Medicare space. You've got to be able to have conversations with our federal partners around this. So if you're going to move forward, we in the past, and we do now, have staff dedicated towards working with the plans around the Medicare products and the dual population specifically. We also pursued the strategy and communicated this to the marketplace in advance of our procurement in 2012, where as part of our Medicaid procurements, and we competitively procure, we told organizations that if they were interested in being D-SNPs, they needed to win a Medicaid contract to deliver Medicaid services if they wanted us to sign the agreements on the MIPPA side. And so we had a few organizations that were D-SNPs at the time. Not all of them decided to enter into the Medicaid space, and so they had to wind down those products. And we did have one relatively large organization that made the decision to come into Medicaid as a result of us sort of putting that marker out there and stating this is the policy objective that we wanted to pursue. We also made the decision to opt out of the dual demos given our use of the D-SNPs. We viewed this as an alternative platform that existed statutorily, that was something that we could use going forward. And while the demos offered some opportunities for states, we viewed it as something in which we probably would end up stepping backwards. So we've spent all of our time, effort, and energy within the D-SNP space, but also leveraging the new resources that exist within CMS to partner around dual eligible issues. We have in place significant financial sanctions for our plans if they do not become D-SNPs. So if you spend much time in this space, you can recognize, particularly in a large state like Arizona that has a lot of rural areas, getting through the network requirements, getting through all the expectations can sometimes be a challenge on the Medicare space. We've had a plan or two that have not met our mandate to become D-SNPs for a limited time period. They may miss a year cycle, and so we've levied significant financial sanctions associated with their failure to become D-SNPs, and our contract requires all of our plans to be D-SNPs to better serve dual eligible members. We pursued strategies to encourage alignment. So we have looked, in about every 18 months or so, we align on Medicare assignment. We give members notice. We give them the opportunity to stay with their existing Medicaid plan. But as part of our alignment strategy, we will align and move. We have moved several thousand members to line up their Medicare and Medicaid benefit by changing their Medicaid assignment. We recently joined Tennessee in having plans get approval for seamless conversion. We view this as an important opportunity to, again, pursue alignment through a federally designated process in which plans have worked to identify those individuals that are becoming Medicare eligible, let them know about the seamless conversion process, but then allow them to basically enroll into an aligned assignment with the member ultimately having the ability to opt out at some point in time if they so choose. We require all of our plans to submit all of their encounter information. So this is something that we've invested a lot of time, effort, and energy on just in terms of building our encounter capacity. We have pretty good data, but by now capturing all of the Medicare space, it gives us a better understanding of the true costs and services being delivered to dual eligible members and really provides for that important repository of information. We also share what's known as blind spot data on members that may not be aligned. So if somebody's sitting in Medicare fee-for-service, we get that information, we distribute that to the plan so they can incorporate that as part of their data analytics. Two other things I'll just touch on very quickly that are not on the slide. We have a very robust strategy around value-based purchasing that we're pursuing, where our managed care organizations have to be implementing on an increasing percentage every year the percent of spend in value-based arrangements. We extend that requirement to their Medicare spend. So we really view this as an opportunity to bring value-based purchasing into the Medicare space, but without necessarily having to get Medicare fee-for-service signed off in terms of what that looks like. We know states have struggled with that, but in the D-SNP world, with the plans responsible for a significant portion of Medicare spend, that's worked out well. And then also we've worked with our plans around marketing, where our policy has evolved considerably in terms of providing plans more flexibility and targeting marketing for dual eligible members. So last slide, very briefly. This is what our world looks like today. We've got 40% of our membership that's in managed care aligned within, and we're mandatory managed care with the exception of American Indians. So 48% aligned, 15% sit in another MA plan, and 37% sit in Medicare fee-for-service. So we've come a long way with roughly 70,000 folks aligned and integrated. So that's Arizona.
Great, thank you, Tom. And just for clarification, someone asked, D-SNPs are dual eligible special needs plan, a type of Medicare Advantage plan. MIPPA is the Medicare Improvements for Patients and Providers Act. And with that, from Arizona, we'll look to a slightly different model in Minnesota with Gretchen Olson.
Hello, good afternoon. You'll notice I don't have any travel pictures for January weather on our Minnesota slide. It's 20 degrees today though, so we think it's a beautiful day. Next slide, please. All right, so I wanted to start with the Medicare Medicaid managed care for our seniors population, because this is the group that we've moved furthest on in terms of integration. In terms of what the contract is that plans have to sign, they actually must sign the full seniors Medicaid managed care contract. They have to offer both the D-SNP aligned product and a Medicaid only product. We combine all of Medicare benefits, including Part D and Medicaid services, using these contract requirements. We also have an enrollment process that plans typically use the state as a third-party enrollment broker so that we can make sure to align Medicare and Medicaid enrollment spans. Part of our contract requires the plan to submit encounter data, including the Medicare encounters. We actually have them submit as if it's one integrated product. We don't ask them to split out Medicare versus Medicaid for the most part, except for pharmacy. We have an integrated appeals process, so it doesn't matter whether the benefit that a person is concerned about losing is a Medicare benefit or a Medicaid benefit. They go to in the same pathway to begin. Let's see, I lost my screen here. Okay. Each of our MSHO plans have unique contract numbers, which has been very important for our plans so that they can create individualized specific marketing materials for this integrated Medicare and Medicaid product. And we have continued support for those unique H numbers under an administrative alignment demonstration, which Minnesota is participating in. It's not a financial alignment demonstration, but it is part of that same demonstration. We just went a different direction to focus on the administrative piece. So our subset, we only allow our D-SNPs to enroll full benefit duals who are enrolled in the same plan for Medicaid. So we have 100% alignment. In addition, our Medicaid managed care contract, which is in effect the MIPPA contract, has an evergreen clause. And this allows us, even though we sign contracts on a calendar year basis, to allow the plans to meet their MIPPA requirements with CMS. And finally, the demonstration that I mentioned allows the state to have input into our Medicare, into the network adequacy on the Medicare side and the exceptions process, which we have found extremely useful. Next slide, please. Some more features of our program, integrated program for seniors. Much like Arizona, we are requiring our plans to invest in value-based purchasing programs, and we think that having this leverage of the Medicaid contract has been extremely useful for us in driving towards improvement on the Medicare side, because after all, these are the same enrollees who are receiving both types of benefits. One of the pieces that we've been able to do because of the unique H numbers and because we have dedicated staff that have worked for many years in this area, we have integrated member materials so that they include both the Medicare and Medicaid information in any given member material. They're not two separate sets of materials for Medicare versus Medicaid. There's one enrollment form. The enrollment dates are aligned both operationally by having the state work as third-party administrator. And we have one card, one health plan card for all services. We have for a long time really touted that to seniors. That seems to be a message that gets across, that you don't need to have a Medicare card, a Medicaid card, and a Part D card. You have one card. It's your MSHO card. Our MLTSS assessment tool integrates the health risk assessment requirements as well. We like to have plans assess enrollees right off the bat and to take care of both the Medicare HRA requirement as well as to assess people for eligibility for our elderly waiver services. Every member has an individual care coordinator. We set the standards for care coordination, but they have very flexible care coordination delivery models, and every plan has a unique way of putting that together. Another piece that has been very useful is just a high degree of collaboration among the special needs plans in the state. We can talk to them, and we have them in our offices on a regular basis on everything from member materials to quality improvement to care coordination, benefit policy, etc. So next slide, please. So the picture for disabled adults in Minnesota is different. We have tried to set up a similar model, but we don't have quite the same authority, and the financing has been much more difficult. We've had trouble. We've tried to bring this up a number of times, and the financial picture has been more difficult for plans. So the current arrangement is that, much like for seniors, a D-SNP that wants to participate has to sign the full special needs basic care Medicaid managed care contract. And it combines all Medicare Medicare services. The Medicaid services are much more limited on the state side. We have, for the most part, left MLTSS out of this arrangement because that is where a lot of the uncontrolled expense has been. Much like with seniors, we limit enrollment to the full benefit duals enrolled in the same plan for Medicaid. And we use the evergreen clause in our contract to help with the CMS MIPPA timing. Plans do not necessarily have guaranteed unique H numbers. This population is not included in the administrative alignment demonstration. Thus far we've been able to wrangle that for historical reasons. We have some concerns going forward because CMS seems to be reluctant to award more than one contract number per plan. We have less cooperation regarding integrated marketing materials. We don't have some of the pieces that we have in the demo for this group. However, we have a lot of great contacts at CMS, and we have a lot of learnings from our senior side. So we're constantly pushing the envelope to make this appear to be a more integrated experience for enrollees. Right now, we are seeing a bump up in the number of people with disabilities in an integrated product because we just had a new D-SNP enter the market in January. And part of that was due to the changes in risk adjustment and payment methodology for dual. So we're very happy about that and look forward to increasing integration for people with disabilities. Next slide. This is just a kind of catch-all slide to give you an overview of what the Medicaid managed care landscape looks like in Minnesota. It's mandatory managed care for seniors, adults, families, and children, but it's voluntary for people with disabilities. 90% of our Medicaid seniors are enrolled in managed care, and it includes all MLTSS services. About 3/4 of them have elected the integrated Medicare and Medicaid. Only about half of our Medicaid adults with disabilities are voluntarily enrolled. The benefit is much more limited, so we continue to do the waiver services via Medicaid fee-for-service. At the moment, less than 2% have elected the integrated Medicaid and Medicare, and that's primarily because the service area has been quite limited, and the marketing has also been limited. So we're looking forward to changing that this year with a new plan on board. Wanted to give you the full name for our demonstration and just explain that the way that we went here is that instead of being a financial demonstration where we had to redo contracting and have people voluntarily enroll again, we decided, because we had a long-standing seniors program, to go with the administrative alignment demo. So the SNPs did not become MMPs, and the current financing arrangement stayed in place. For members, there really was no transition. They didn't have to opt in again. And it also helped us strengthen our bid, we believe, to integrate the value-based purchasing. Next slide, please. All right, that's it for now. I'll look forward to hearing questions later. Thanks.
Thanks, Gretchen. Really appreciate it. Interesting stuff. Let's move now to Tennessee and hear from Patty Killingsworth.
Okay, great. Thanks. If you can go back to Tom's slide and just sort of envision that beautiful picture of the state of Arizona, and if you sort of split that in half and put the Smoky Mountains of East Tennessee on the other half, Tom and I could perhaps share slides, because very much about our conversations are the same. I think the same kinds of goals that have caused us to really pursue an integration strategy for dual eligibles are the same ones that Tom talked about. We are seeking high quality, cost-effective services and supports. We believe in integrated models of care, and we've pursued that with many of the same strategies. Like Arizona, we withdrew from the financial alignment demonstrations in favor of leveraging the D-SNP authority, ultimately hoping that the future will hold even more integrated pathways than the D-SNP authority permits. But for now, this is a good approach for us. Like Arizona and like Minnesota, we too are pursuing value-based purchasing. We are doing that in a way that really cuts across payers. So we are seeking to engage Medicaid, Medicare, as well as commercial health plans in an effort to really align efforts at the very direct point of service around key quality and cost efficiency goals. So lots of the same kinds of things that I think we're working on. If you turn to the first slide in mine, just talking about our efforts toward integration and alignment. Like Arizona, we have leveraged the procurement process on the Medicaid side to really try to get to better alignment for dual eligibles, requiring our health plans in the last procurement to either have a statewide companion D-SNP already operational or to commit to developing one as a part of that procurement process. That was a process that kicked off back in 2013 with statewide plans being implemented in 2015. So we now have 3 statewide Medicaid MCOs, all of whom have companion D-SNP plans. We do also have 3 non-Medicaid D-SNPs that we at this point have not elected to stop contracting with at this point, just concerns about continuity of care for the members who are enrolled in those plans. But we have committed to not contracting with any additional D-SNPs that are not Medicaid health plans. We're really looking for an integrated model going forward. As a part of implementing those statewide MCOs back in 2015, a key part of our reassignment process was to really look at opportunities for alignment with the Medicare plan. So we looked at where members were assigned or had elected an assignment to a D-SNP plan and then sought to realign their Medicaid enrollment with their D-SNP plan wherever we possibly could, and achieve some significant improvement actually in alignment as a result of those reassignment efforts. From a hardship perspective, we are looking to modify our hardship criteria so that one of the reasons that we would permit a Medicaid member to change health plans outside the annual enrollment period would be to achieve alignment with their Medicare plan. And we have a pretty robust member education process, really trying to help members understand the value and benefits of being in an aligned situation, and also helping them think about the kinds of considerations that they may have when they are choosing their Medicare plan, things like maintaining continuity of care with primary care providers and those sorts of things. A big part of our progress has been with the seamless conversion process, really working with our contracted Medicaid plans that have companion D-SNPs to support them in implementing seamless conversion of Medicaid enrollees as they attain Medicare eligibility in a way that comports with the federal requirements. So there's a lot that we do there to really support that process. We submit prospective Medicare enrollment dates that we derive from our MMA file submission process to each of the Medicaid MCO plans and their companion D-SNP. That assists them in identifying the members who are attaining Medicare eligibility, so we can ensure that people are uniformly notified and have that same opportunity. And as well as the health plan meeting their obligation to send notification to the member in advance, we also send an educational letter to the member, really letting them know that that letter is going to be coming, but also telling them again the benefits of enrolling in an aligned situation and encouraging them to maintain that enrollment as that seamless conversion process happens. So turning to the next slide, as we get people into aligned situations, or in some situations where they're not in aligned situations but they're in a different D-SNP, we want to ensure that there is effective coordination of care or benefits. We do exchange full Medicaid enrollment files with all of the D-SNPs, including the non-Medicaid D-SNPs, so that they know what a member's Medicaid MCO assignment is. We provide Medicare enrollment data to Medicaid MCOs for the same purpose, so everybody knows where people are receiving their Medicare benefit in order to be able to coordinate their care effectively. We've leveraged those MIPPA agreements to really strengthen the coordination requirements for D-SNPs, particularly around 3 areas: discharge planning, care transitions, and the use of long-term services and supports, making sure that Medicaid health plans and Medicare health plans are working together, or where it is an aligned situation, which is clearly our preference, that systems are integrated in a way that really supports effective care coordination. So a care coordinator needs to be able to see all of the information pertaining both to to the Medicaid and the Medicare benefits in order to identify and address gaps in care and effectively coordinate care across the continuum. Our D-SNPs are required to exchange daily inpatient admission and discharge reports, including observation stays. And again, all of that is about facilitating timely and effective discharge planning so that we can ensure that people receive the most appropriate care in the most appropriate setting. And then quickly taking a look at some of the successes that we've achieved. So all 3 of our Medicaid MCOs have been approved by CMS for seamless conversion. And actually between the time that I prepared this slide and the time that we are conducting this webinar, we now have all 3 health plans who have implemented seamless conversion. The first files went to our 3rd health plan at the end of last week, and so they'll be sending out their first round of seamless conversion notices at the end of this month. So now we have all 3 health plans who are really implementing that process. As a result of just the first 2 health plans that had previously implemented seamless conversion, we do have 22,000 more full benefit dual eligible members who are in D-SNPs, and that's a significant increase, over 50% since December of 2013. The vast majority of those being in aligned situations. If we look at the increase in aligned membership for plans who are implementing seamless conversion already versus the one who is just getting started, substantial differences in terms of the increases in aligned membership. You'll see that over 5,000%, that's a plan that literally was developing its D-SNP as we were implementing our new procurement process. Very low opt-out rates. The vast majority of people are choosing to stay in the aligned situation, with most of the loss of enrollment, if you will, being really related to eligibility factors and things like that. An 80% retention rate overall. As we look at provider networks and really ensuring continuity of care for members, we see substantial overlap in the Medicaid and D-SNP provider networks, and actually that's one of the requirements that we have in our MIPPA agreement, and we look at that on a periodic basis to really evaluate the extent to which those networks are overlapping. And then finally, integrated care management systems and processes, which I mentioned previously. So lots of opportunities still to come, but also lots of progress that we feel that we've been able to make in the short amount of time that we've really been focused on this effort.
Great, Patty. Thank you. We are going to ask each of the speakers when we conclude to give us their key lessons learned, but before we do that, we want to turn to some of your questions. Let me start with one that's for both Tom and Patty. And I guess for Nisha, there's a CMS moratorium on seamless conversion, so tell us more, speak more to how is that impacting the use of seamless conversion?
So this is Patty. If I can just sort of start out, I think Arizona and Tennessee are in a fortunate place in that the moratorium doesn't impact plans who already have approval, and so we're grateful for that. And I think the Tennessee and Arizona plans already had approval, so nothing is preventing us from moving forward. I think CMS has been very open to conversations with Arizona, Tennessee, and I think other states as well, really digging into the concerns that are out there and understanding that full benefit dual eligible D-SNPs are very different from other kinds of MA plans who may be implementing seamless conversion. For the most part, we are really talking about a process that tends to preserve continuity of provider relationships rather than interrupting them. We're also talking about a population who currently has the ability to opt in and out of plans on a monthly basis, so they're not locked into a situation that they don't want to be in. These are arrangements which are substantially improving the quality and coordination of care that's being delivered to the population. And I think once CMS really has a time to fully dig into the concerns that have been raised, we may see a very different approach with D-SNPs than we see for MA plans, where some of those the factors and systems may be different.
Great. Tom, anything to add?
Really the only thing I would add is Patty had the data on her network overlap, and it's similar in Arizona, again, given that strong network overlap. This really is a continuity of care issue as it relates to dual eligibles that differentiates it. And then the other thing is the Minnesota study that's out there that is a third-party evaluation of their efforts to date, I think is really a validation of these efforts and the strength of this alignment in terms of improving outcomes, reducing hospital admissions and readmissions. So I think there's definitely proof out there to support this, and this is completely different than some of the discussions that are occurring around the other seamless conversion processes.
Nisha, anything to add from CMS?
So I think one of the things I would say, and I know that Patty mentioned this, is that the seamless conversion, CMS is creating a policy that's applicable to all Medicare Advantage plans, and D-SNPs are Medicare Advantage plans. But our concern is for beneficiaries, and we want to make sure what we're doing is best for beneficiaries and best for the program. And so we are trying to be very open and listen to the concerns that we're hearing about from both sides of the line. That's it.
Okay, thank you. There are a couple of questions for all of the states about when do you make a choice about pursuing a fully integrated designation or not? What are the sort of pros and cons? How did you make those determinations?
So from Tennessee's perspective, our MLTSS benefits haven't been integrated for a long time. We integrated nursing facility, home and community-based services for older adults, adults with physical disabilities in 2010, and just this year for people with intellectual and developmental disabilities. And so we're really just now at a point where we've got the LTSS benefits integrated across the continuum in a way that we really think would support the fully integrated model. And so it's probably time for us to step back and reevaluate that at this point.
Others want to weigh in? Question or Tom?
This is Minnesota. So I think that the state program considerations really need to come first. And the focus really has to be on the enrollees and what systems work best. I think for us, with the people with disabilities population, it really turned on what type of programming is really the most stable for folks, and really not on the designation piece.
Anything else, Tom?
No, I really don't have anything to add on that, Trish.
Okay. There are a couple of questions about members selecting plans, and how often do members select the same D-SNP and MLTSS plan?
Well, seamless conversion is certainly something that promotes people selecting the same plan. And remember, they're selecting a plan essentially that aligns with the Medicaid health plan they've already been with. So we think from a continuity of care perspective that makes a lot of sense for people. It's one of the reasons why we think that in CMS's development of their policy that they need to think very carefully about the differences between D-SNPs and other MA arrangements and the impact that it has on dual eligible beneficiaries. I think there could be some very negative unintended consequences if we sort of paint everyone with the same broad brush. Beyond that, I think there's a lot that Medicaid agencies can do to help educate dual eligible beneficiaries about the benefits of being in an aligned health plan situation, and we've tried to integrate that within a lot of our member materials, as well as some of the enrollment discussions that we have with members. In terms of being able to give you actual percentages, I can't right offhand tell you when a person is choosing, how often do they choose. Again, from a seamless conversion perspective, when they're assigned, the vast majority of them choose to maintain that going forward.
Great.
I think, Trish, just to add, one of the challenges here is you're not necessarily selecting both at the same time. Often we're talking about folks that are Medicaid eligible and then become Medicare eligible, or are Medicare eligible and becoming Medicaid eligible. And so just like Patty said, we're trying to provide a lot of information. We've, as I mentioned earlier, expanded sort of what we've allowed for the plans for marketing and education on these different choices that members have to make. But I think that's one of the challenges, is just the confusion of I'm in these two separate products, which historically have not done a good job of working well together, Medicaid and Medicare. And I'll reiterate Patty's comments too. I don't think the Medicare side often views Medicare singularly, and I do hope that as Medicare looks at the issue around seamless conversion and other issues, there's some differentiation for the world that the duals are living in. So just use that opportunity. But I don't have specific data. We've achieved roughly the 50% alignment without even the seamless conversion going into place. So there's not much churn in terms of our members opting out of what they've chosen to enroll in.
Great.
This is Gretchen. I just wanted to add that I think we have to continually remind ourselves how confusing the landscape is for seniors and their families in terms of trying to understand Medicare versus Medicaid and all of their options. In particular, a recent focus group that we did found that part of the reason we were having some trouble getting people of color to enroll in the integrated product, especially in the African American community, was a concern that there was an attempt to defraud, that mailings from insurance companies were seen as potentially fraudulent. And so having the state be engaged in that communication and trying to keep it very direct and to the point is helpful for enrollees.
Great. Let me flip to data, because we've got a couple questions on data. One asking if you use data to attribute duals to providers and plans, and the other asking for a little bit more clarification on the blind spot data, which I think was Tom. So both attribution of duals to providers and plans and blind spot. Who wants to start?
So this is Tom. I'll just start with the blind spot data, and that is, for those duals that are not aligned. So an individual sits in Medicaid managed care and sits in Medicare fee-for-service. We do get the A, B, and D data from CMS, and so we share that back to the plans for the members they're responsible for. Obviously, it's far from real time, but it is information that they can put in their analytics systems that help identify sort of their high needs, high cost members, so they're able to access that. So that's sort of our blind spot project that we have in place. What was the other part of the question, Trish?
Whether you can attribute Medicare and Medicaid data to providers and plans.
So, I mean, the plans get their data. I'm not sure I fully understand the question. I mean, we get provider level information, we get plan level information. We are able to look at different performance for the various plans and providers. I'm not sure if that's what's meant by attribution.
I think the question is on whether you use integrated Medicare and Medicaid data.
I mean, for us, yes, we have access to both in terms of evaluations.
Okay,
This is Patty.
How's this for real time? The question is clarifying it. That is integrated Medicare and Medicaid data used to match beneficiaries with providers and plans.
No, we don't.
So, yeah, and I will say, so from an integrated data, in terms of plans, clearly members choose their Medicare plans, and they also choose their Medicaid plans. And so we're not actually matching them, except, as I mentioned earlier, when we did our reassignment process, we were actually reassigning some of our Medicaid membership. We did look at their Medicare enrollment data in order to match them from an enrollment perspective. We weren't using claims data or anything like that. We were really using enrollment data. I think from a health plan perspective, they're absolutely looking at integrated data. So for example, if you are a D-SNP plan and you are enrolling someone on the Medicare side who has been your Medicaid member, you're going to look at their Medicaid data to really see who their primary care providers have been and those sorts of things to try to ensure continuity, I think, as you begin working with them on the Medicare side. So to the extent that that's what you're talking about, I think those sorts of things happen at a plan level.
Yeah. Let me flip us to the lessons learned. I don't want to run out of time, and we're perilously close to doing that. So I want to ask each of the 3 states to give us the key lessons learned. Obviously, this D-SNP is a great tool if used creatively, as you 3 have very much done. What are sort of the lessons learned? And let me add a question. If you had the magic wand and could change anything at CMS that would make the D-SNP program work better with duals and with Medicaid, what would that be? So let me start with Tom.
So I would, our lessons learned, this is a multi-year project. This is not something that you can do and expect to be done in 12 months. It's really something you're dedicating your organization to. So you're picking your path, and at this point in time, you're listening to D-SNP, and so hopefully that's a path that you're interested in, whether it's talking to other states, and many other states have been a tremendous resource for us. 2 of them are on this call and having the conversations because it is complex. So identifying what your vision is, figuring out sort of what those multi-year steps are, engaging your managed care organizations, because at the end of the day, they're the ones that are going to have to carry this out. Really looking at what your contractual requirements are around that, ensuring you're getting good data, and having that staff resource available that can understand the complexities, the ins and outs of the Medicare side of this, and more holistically, the D-SNP applications of it. The one thing as it relates to CMS, I don't have a specific policy area, but it's again that continual emphasis that we cannot look at Medicare sort of monolithically, and there's different populations being served, that we share the same member, we share the same interest as it relates to improving outcomes for that member, and oftentimes we've made this incredibly complex, and really what we need to do is come up with systems of care that are understandable and manageable and recognize some of the distinct differences that exist for the dual populations that we're serving.
Great. Thank you, Tom. Let me flip it to Patty.
So I'm going to keep mine really short. I think it's really around partnering. I think what we have found to be the most effective in this entire process is really partnering with our health plans to identify the programmatic goals that we want to accomplish and then figure out how to work together to accomplish them. Case in point would be how we've approached seamless conversion, really with us taking a role in helping to identify the membership, also helping to educate members, and then providing them with some of the tools and information they need to really be able to successfully implement seamless conversion. So it's been very much a partnership, and we've tried to do that across the board as we approach this. If I could change one thing about federal policy as it relates to D-SNPs, I would say that there has to be easier ways to really achieve full integration of the Medicare and Medicaid book of business for this population, where you are literally blending contracting and funding streams and all of those things together in a way that feels much less administratively challenging than did the financial alignment demonstrations, because ultimately that's what will get us to better quality and cost efficiency for this population.
Great. Thank you, Patty. Gretchen, lessons learned?
Yeah, if you want to flip back to my slide there, this is the study that Tom pointed out for folks. The primary lesson that we've learned is that this really works. It has a significant impact on people's lives. So when people are in an integrated product, in Minnesota we've compared the Medicaid only and the integrated product. There's significantly positive impacts in terms of less hospitalization, less emergency department use, 2.7 times more likely to have seen a primary care provider in the past year. And we believe a lot of this is because of the ability to do care coordination across the primary care, Medicare benefits, and the long-term care community supports state MLTSS benefits, as well as the state and Medicare behavioral health benefits. So please take a moment to check out the study that has been done by a third party. This effort is really worth it for seniors and people with disabilities. It makes a great deal of difference to integrate care. So,
Gretchen, thank you. And any last words, Nisha, from CMS?
First of all, thank you. I really enjoyed being a part of this conversation, and I think that's one thing I'd like to reiterate is that we want to encourage states to use the discretion they have when they contract with organizations, and if they want to see more integration, to go above and beyond just those basic MIPPA elements, because we'd like to support that effort to improving care for duals as well.
Fabulous. This has been a terrific hour, really filled with information. The slides will be up on our website as soon as we can get them up there. I very much want to thank, I have to say, we do a lot of these webinars, and it's rare that you get the high number of people who start a webinar are still with you, and you're all still with us, so thank you all for joining us. There is a survey at the conclusion of this we beg you to answer so we know how to make these webinars as valuable as can be. I really want to thank Nisha Marie Sherry from CMS, Tom Betlach from Arizona, Gretchen Obey from Minnesota, Patty Killingsworth from Tennessee, and thank you to the Commonwealth Fund for really a wonderful opportunity to talk in depth about a really innovative set of state practices and coordination with CMS. So thank you all. Please fill out the survey. It helps us make these better. Thank you, Nisha Marie, Tom, Gretchen, Patty. We are out. Over and out from Nashville. Thank you all.